Hey everyone, my name is Danielle Heinlein-Ball, and today I'm going to talk to you about wilderness first aid for paragliders. The purpose of this presentation is to help listeners develop a baseline knowledge on wilderness first aid geared towards flying. Although this presentation is aimed more towards paragliding, pretty much any concept, if not all concepts that we talk about, can also be applied to hang gliding as well. Objectives of this presentation include understanding the roles in a medical emergency, understanding the process going from assessment to implementation and then finally evaluation related to an emergency, understanding the basic concepts of first aid related to various medical conditions, and then lastly we'll finish off with some logistics and understanding how to communicate with EMS or emergency medical services. I hope you enjoy this presentation, and let's get started.
All right, so this is Basic Wilderness Medical Aid for Paragliders. Just a quick about me before we start. I've been a registered nurse for 7 years, and then I am a new graduate nurse practitioner. I have experience from medical, surgical, neurotrauma, pediatric, ICU, emergency, and then most recently urgent care. I've taken 2 wilderness first responder courses. I do have an active WOOFer certification right now. And then I'm currently completing my Fellow of the Academy of Wilderness Medicine. This presentation is actually for partial fulfillment of those credits. And then I started paragliding in 2017 at the point of the mountain in Utah. Just a quick disclaimer before we go further. This presentation is for educational and informational purposes only. It may not be construed as medical advice. The content provided does not substitute for professional medical advice or consultations with healthcare professionals. Information has been gathered from reputable sources, but viewers should not rely solely on this information, and the use of the information from this presentation is at the viewer's own risk. Any opinions presented are my own, and I do not represent any affiliations or organizations. So what makes first aid for paragliders unique? First of all, accidents can occur with limited supplies. So obviously paragliders don't have a lot of room in their harness, and they also don't want to put a ton of weight in the back of their harness. So that's going to limit what they're able to carry as far as medical kits. Injuries can occur in remote settings, so pilots are flying in mountainous terrain or on long cross-country trips. You can land in an area that there's no service, no nearby aid at all. This sport is inherently high risk and has a lot of high risk injuries. So every part of paragliding has its own injury risk to it. So the hike up and then maybe that hike back down. There's the launch, the flight, the land. These all have their own opportunities for something to happen. So best thing to do is just focusing on prevention. We're able to help avoid these accidents by knowing our flying limitations, increasing knowledge on weather and understanding conditions. We can wear protective equipment like helmets and back braces, and then overall just maintaining our skill with regular education. So I did a little literature review. It was about 6 studies that I looked at. They were pretty much all from European countries. They found that newer pilots tend to experience injury more often. Between 40 to 75% of the pilots injured in these studies that I looked at were trainees, or they were pilots who had less than 100 flights. However, it's important to note that experienced pilots did also experience injuries as well. These were associated more with incorrectly handled collapses that then resulted in injury. And this was thought to be related more to using high performance gliders and having inadequate training to use those wings. So studies varied on if spinal injuries or lower extremity injuries were more common, and they also varied on soft tissue versus fractures being more common. However, polytrauma or multiple injuries were found frequently in accidents, so you might see all of these things combined. Powered paragliding was one exception. You might actually see more upper extremity injuries, which is due to engine involvement, including contact with the propeller, and then also just the weight of the engine causing injury itself. More accidents were reported with paragliding versus hang gliding. Paragliding tends to have less accidents compared to other extreme sports, but these accidents do tend to be more fatal. Injuries, whether they came from mid-flight or landing, this kind of varied as well, but more of the studies reported mid-flight as being the most frequent cause of injury. Wing collapse was specifically mentioned as a high cause of fatality. And then again, powered paragliding was another exception here. Accidents actually were found to be more frequent with takeoff. The primary causes of death included major artery injuries, intracranial hemorrhages, cervical fractures, and pneumothoraces, or collapsed lung. It's not enjoyable to talk about these, but knowing the injuries and the type of causes of fatality is going to help us prepare better and just know what to expect when an accident happens. So, for the role of the non-medical responder, this is going to vary situation by situation, but ultimately never perform duties that are outside of your abilities or your comfort zone. So make sure you're learning about different conditions and the treatment for those conditions, but only do what you have been taught to do and research what you are allowed to do. If you're a healthcare provider, you have to stay within your licensed scope of practice. So make sure you're familiar with that and determine what your role would be in a non-medical environment situation. Some treatment methods discussed in this presentation might not be appropriate for every single person listening, but we'll still talk about it just for the purpose of awareness, and that way you kind of know what to expect in an emergency and what might be going on. Make sure you're available to help medical responders, but you also don't want to get in their way. So if there is no role for you, please give space and encourage other bystanders to do the same. You can look for non-patient roles, such as keeping the crowd at bay, ensuring privacy for the patient. You can ask the patient if you can contact their family or their friends. You can also ask them if they have any pets at home that need to be taken care of, kids that need to be picked up, anything like that. You can organize who will transport the patient's belongings and their vehicle if applicable. And then finally, you can also station yourself along the roadside or anywhere that you can help guide EMS to get to the patient a little bit faster. So when in doubt, always call 911 and always follow whatever EMS instructs you to do. Moving on to some first aid basics. All right, so starting out with our initial assessment, this is always going to begin with scene safety. So if you're flying and you see your friend go down, you need to make sure that you keep your wits about you, continue flying, and land wherever it's safe to do so. That might mean that you're a little bit farther away from where your friend landed, but again, the most important thing is that you are able to get down versus becoming a second victim by just rushing down in an unsafe manner. Once you're down and by your friend, make sure that you are securing that wing, whether you can actually take off their harness, if it's safe to do so, spine considerations, or you might just have to cut away their lines, whatever it is to secure that wing. I attached a video here. Some of you may have seen this before, but I want you to look at it from the standpoint of pretend the two guys in this video are your patient and a dust devil comes through. So yeah, that is pretty terrifying, and definitely really hammers down the idea that you need to secure that wing, cut it away, do whatever you have to do. So next up is establishing a leader. So teamwork is essential, but we want to avoid chaos. Normally a leader will kind of naturally emerge in a group setting like that. But it also can be discussed as you're approaching the patient, saying like, hey, I've got this experience, et cetera, et cetera. If you are the leader, make sure that you're being very specific in your delegation. Point to people directly when you're asking them to do tasks. When the leader does give you a task, make sure you're using closed loop communication. So you're repeating what they said to you. For example, if I say, hey, hold pressure on the wound on their leg, you would say, okay, I will hold pressure on the wound on their leg. So there's no room for misunderstandings. Humble yourself and realize that other people, again, might have more experience than you, and they may be a better leader than you in that given scenario. Then also, if you see something, say something, but make sure you're not deviating from the task at hand. So while you're holding pressure on the leg, and all of a sudden you notice that they have a penetrating wound in their abdomen, you're not going to let go of their leg, but while holding their leg, you'll get somebody else and say, hey, look at this, there's another wound here, and then they can address that. It is always important to introduce yourself and ask for help before you lay your hands on somebody else. This might look different depending on the severity of the scene. Obviously, if someone is unconscious, you can't obtain consent. That's just implied. If someone is very unstable, as you're running up, you can say, "Can I help you?" And they'll say yes. But if someone's just sitting there, they're not in distress, introduce yourself, actually ask. Don't just, go start putting your hands on them. For your initial assessment, you can gain a lot of information by just looking at the patient as you walk up to them. So really utilize that time. Just the moment that you're walking up, there's so much that goes on during that period. So you can look for any massive bleeding. Is there a puddle of blood underneath them? Do you see actual bleeding happening? What's their skin coloring? Is it normal for ethnicity? Is it blue, gray, pale? What are they doing? Are they laying there? Are they panicked, grasping at a certain body part? Do they look at you as you approach? Do they seem confused, disoriented? Are they struggling to breathe? And then also keep in mind, was there a positive mechanism of injury, or MOI, for spine injury? And are you going to need to stabilize their spine once you reach them? So all of this stuff should be going on in your head as you're walking up to them. And then once you do get up to them, we follow the ABCDE approach, which we'll talk about on the next slide. And then if they have any red flag findings, make sure you're calling 911 immediately, or getting them to the ER right away. So ABCDEs. We say ABCDE, but there's actually a little C right before all of that. So first thing you're always going to do is rule out any massive hemorrhage first. So again, as you're walking up to them, do you see any bleeding? The first thing that is going to kill someone is if they're massively bleeding out. They can die in a couple of minutes. It's a very quick process. So check for that. Ensure that there is no threat there. And then once you have determined that, then you can move on to that ABCDE process. So with that, another little caveat is you always make sure ABC are stabilized before you hit D and E. So it might be ABC, 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 okay, stabilized, now D and E. For airway, we're going to ensure nothing is obstructing the airway. Look for blood, vomit, missing teeth, foreign objects, tongue. That also can obstruct the airway. If their tongue is obstructing the airway, you may need to do some maneuvering. So as you can see in that photo there, the jaw thrust maneuver, he has his hands at the base of my jaw and he's pushing it forward to open up that airway. It's not comfortable, but it is effective. If there's evidence of low or diminishing alertness or neurologic status, any facial fractures or neck trauma, any of that, you're going to rapidly need to access medical care, as airway may be becoming compromised or may already be compromised. For breathing, you want to look and see if their chest is rising and falling symmetrically. You want to see if the patient is spontaneously taking breaths. Also look for any difficulty breathing. Are they using their whole body just to take breaths? Any asymmetric chest shape, something we call tracheal deviation. So the trachea, right in the front of their neck, is it crooked off to one side? Any open chest wound indicating an open pneumothorax. All of these will indicate a very serious current or impending issue. Obviously, if breathing stops, you want to check for pulse and then begin CPR. I do want to make a note on open pneumothorax. If you remember, pneumothoraces are one of the common causes of death with paragliding. So if you do find that your patient has an open chest wound, you need to apply a seal. Ideally something like a plastic bag, any sort of occlusive dressing that you can put over that chest wound. So it needs to be occluded by 3 sides. We call it a 3-sided dressing. The reason for that is because we want we want the seal to completely occlude and seal the wound when the person's breathing in, but when they're breathing out, we want the air to be able to escape. So you will say you have a plastic bag, you'll tape down 3 sides, and then you'll leave that 4th side untaped. That way when they're breathing out, it can still burp, is what we call it. If you notice that the person is having increasing difficulty breathing, make sure you look at that seal and make sure that it hasn't completely occluded, whether it's from bleeding and blood clots, or just something going wrong with your chest seal. Another thing that you can do for breathing is the tripod position. So you can see there's the photo there. He's just leaning forward, and it's just taking off the gravity and the weight of his chest so his lungs can expand a little bit easier. So for circulation, again, the biggest thing is going to be bleeding control, which we've already ruled out massive hemorrhage. We did that before airway. But again, you'll make sure that there's no other bleeding. This is one of the areas that we really can address in the wilderness as bleeding control. So check all over their skin, make sure that there's no external hemorrhage going on. Further on with circulation, you can check their fingers, make sure that the skin is nice and normal for ethnicity. It's not pale or blue. Ensure that there's no other bleeding anywhere else. You're going to check their pulses, weak pulses, pale skin, penetrating wounds, cold and sweaty skin. These all can indicate a very serious issue. Apply pressure for wounds, get medical care as soon as possible. These people might need IVs, fluids, and maybe even blood products. Disability is referring more to neurostatus and level of consciousness. So in healthcare, you might hear them talk about the Glasgow Coma Scale, or GCS. So you don't really need to memorize this, but you might hear it. Basically, it's just assessing the person's level of consciousness and rating it. There's kind of a little algorithm that you choose a number for each area. So that's 15 is the highest and the best. But again, I don't think you really need to memorize that. For checking pupils, you want to look and make sure that they are the same size, the same shape. Do they react quickly? If they're slow, that can be a possible indicator for an increasing intracranial pressure, or ICP. Decreased consciousness also could be from a circulation issue or a respiratory issue, and you also want to consider if the person's diabetic. All of that can contribute. So the last one is going to be expose and environmental control. So expose the skin and assess them. Then make sure you're covering them back up so they're not exposed to nature. You're looking for any obvious injuries, again, any bleeding, and then putting blankets on them, extra clothing, maybe even the wing. You really want to keep them warm. This is very important for any sort of trauma-related patient. We want to avoid hypothermia at all costs. So with exposure, that does include looking at the full body, looking underneath, on the belly, actually looking at their skin. But the caveat there is just obviously trying to maintain as much privacy and respect for the person, but you also really do have to be thorough because this is, life and death. So make sure when you're doing all this that you're assessing their entire body. Don't get caught up on one injury until you've ruled out any life-threatening injuries elsewhere. So say they have this crazy open fracture down in their leg. Don't get caught up on that and then miss the fact that they're actually having an issue with their breathing. So do your full assessment before you just get caught up on one spot. And then with all this, make sure you're keeping spine precautions in mind if they have had that positive MOI, which they probably do if they were paragliding. So some assessment red flags: massive or uncontrolled bleeding, difficulty breathing, abdominal pain, altered consciousness or confusion, open fracture, concern for head or spine injury, loss of sensation, movement, or circulation in an extremity, loss of bowel or bladder function, and then trauma to the chest or abdomen. This is not an all-inclusive list. There are several other things that would constitute a red flag if you are out in the remote wilderness. Even something that's just a minor problem in the urban setting could really be a serious problem in the remote environment. So this is really just going to vary, but this is just kind of give you an idea. So moving on to our complete assessment. So you can start out with vital signs. Heart rate, you will place your finger on the inside of the patient's wrist. In that photo, you can see there, that's the radial pulse check. You can count for 30 seconds and then multiply that by 2. So normal adult is going to be about 60 to 100. Athletic adults can definitely be in the 50s, and that's all right. If the person is particularly anxious, though, you may see heart rate up in the 120s, 130s. That's all right, but reassess it once they've calmed down a little bit. Respiratory rate is going to be watching their breathing and seeing how many times they breathe in 30 seconds. And then again, multiply that by 2. So normal is about 12 to 20, but same thing with heart rate. It can definitely be high with anxiety. Little tip on assessing respiratory rate: if you tell someone that you're watching their breathing, sometimes they can kind of breathe a little more sporadically. It's awkward to have someone watch you breathe. So pretend you're just counting their pulse still and then watch their breathing, and it's just a little bit smoother. For ANO times 4, that means Alert and oriented times 4. So 4 is person, place, time, and situation, or what's going on. So make sure the person can say their name, the year, where they are, and then what's happening, what happened, what's going on. So skin color and temperature, this is going to help us understand blood perfusion and any signs of shock. Try to obtain as much medical history as possible. So asking them their name, age, allergies, medications, any medical problems. I recommend specifically asking things like diabetes, seizures, asthma. Sometimes if it's just so normal to the person that they have asthma, they don't even think of it as a medical problem anymore. So specifically asking about those can help a little bit. This is especially important if the person is at risk of losing consciousness. So you might be the last person to actually talk to them before they lose consciousness, and you can then relay that information on to EMS. Make sure you're specifically asking about blood thinning medications or any cardiac or blood pressure medications. EMS and the ED providers will want to know those specifically. Remember that obviously this information is confidential. It should only be shared with those who actually need to know. For your head to toe exam, again, obtain consent if the patient is alert. Make sure you're telling them what you're doing and ensure that they are comfortable with that exam. If it's possible, they may be more comfortable with a member of the same sex if that is, if there's somebody there that can do that. Make sure that you aren't skimming past injuries. Skin can tell us a lot, so while maintaining privacy and dignity, assess areas like the abdomen, any skin on the extremities to ensure there's no deformity, laceration, or bruising. Make sure you're physically feeling for deformities like broken bones or hematomas, which are soft, squishy spots, basically bleeding under the skin. Make sure you're gently feeling around their head, but then you make sure that you're keeping in mind the spine stabilization if it's warranted, so you're not moving them around unless you really have to. And you can ask the person to stay still as well. So record any injuries and findings, make a list in your cell phone. That can make it a little easier to remember everything when you're talking to EMS. And if there is more than one responder present, you can have one person actually doing the exam and the other person recording the findings. And that can kind of expedite the process. All right, so planning and implementing interventions. Obviously, first thing is going to be get help. So 911 right away if that's been deemed necessary. Watch out for the bystander effect. That's when someone asks people to do something and everyone kind of just stands there. So specifically point out to somebody to do something, and you're more likely to actually have them do it. After assessing injuries, we want to make a plan. Remember that you need to stay within your abilities and your scope, and unfortunately, sometimes all we really can do is just provide comfort as we wait for EMS to show up. Always focus on your ABCs. Find out what's going to kill them fastest and focus on fixing that. So maintaining airway, controlling bleeding, stabilizing the neck, those are all high priority. Be aware of those distractor injuries that can divert your attention away from life-threatening injuries. As we discussed, don't let the open fracture take your attention from the difficulty breathing. Your plan is going to depend on when EMS is going to show up. So, for example, if you aren't in the remote setting and EMS is on their way, you're not going to do this super huge splint on an extremity because EMS is going to want to take a look at it anyway. So you're going to focus more on just stabilization and aiding in comfort. While you're implementing interventions, make sure that you are keeping the person involved, keep them updated on when EMS is arriving, and just really try to keep them in the loop. Psychological first aid is important as well, so using therapeutic communication, make sure you're not just making assumptions, and do try to allow them to be involved in their care and in the plan in general. So last is going to be evaluation. So checking in on when EMS is arriving, you want to talk to dispatch, listen to whatever they say and instruct, monitoring for scene safety, and if anything changes, moving yourself and the patient out of harm's way if that's been deemed necessary. Monitoring injuries and rechecking vital signs as needed. If someone is in a very serious injury, situation, it is definitely reasonable to be rechecking even every 5 to 10 minutes. Monitor wounds for bleeding, applying additional bandaging on top of current bandaging. Make sure you're keeping the patient warm and comfortable. And then if that person does lose consciousness, doesn't have a pulse, you're of course going to begin CPR. This is your reminder to go take a CPR class. And then lastly, just be prepared to share your findings and what interventions you've done with EMS once they've gotten there. You will need to be ready to do that quickly, succinctly, because once they get there, they are moving quick. All right, so moving on to conditions. We're going to start out with wounds. So, as we've been talking about, bleeding control is really the most important thing. Any spurting blood is going to be an indication of an arterial bleed. So this needs direct, constant pressure or a tourniquet, which we will talk about on the next slide. For cleaning out a wound, more geared towards remote setting, we recommend cleaning out with high pressure irrigation. You can kind of see in that photo, that's what he's doing there. Do that if possible. You can improvise this with a squeezable water bottle. You can poke a hole on the top of a disposable plastic bottle. I recommend carrying a fine point syringe to irrigate with. Soap and water are just fine for simple wounds. You don't need hydrogen peroxide, contrary to popular belief that actually can interfere with the wound healing. So potable water is ideal, but any water is going to be better than nothing. For dressing, you want to keep that wound clean and covered. Use the cleanest materials that you have. You want to monitor for changes in the wound and the surrounding skin. You can draw a line around the wound if there's any redness that you want to make sure isn't growing. For a penetrating wound, you will leave the object in place and don't move the patient unless absolutely necessary. So removing that foreign body can actually cause uncontrollable bleeding and further tissue damage. So we want to avoid that. If EMS is on their way, focus more on bleeding control and comfort. They will want to reassess wounds anyway, so don't make it challenging for them to access the wound if possible. So avoid these huge, heavy, bulky dressings if you don't need to. It also may be worth putting a pair of gloves in your medical kit. For hemorrhage, we are going to want to apply direct pressure. Usually that's going to be sufficient to control most bleeding. Pack and stuff the wound with the cleanest material you have, ideally gauze if you have it. Apply steady pressure with both hands until the bleeding stops. So you're going to have to push very hard as you can. You want to apply a pressure dressing, so place a bulk of material right on that wound and then tightly wrap around it. A tourniquet is going to be indicated for any uncontrollable bleeding or life-threatening bleeding, which we'll talk about here in just a sec. So yeah, looking at that photo, they cut the pant leg open, stuffed the wound, and applied really intense pressure. Moving on to tourniquets. Only use a tourniquet if bleeding won't stop or if the life is threatened. If you've decided that you need the tourniquet, do not delay putting it on. There's an increase in survival with tourniquet application before shock occurs, so you need to do it right away. You may have heard of the high and tight rule. That's where you quickly apply a tourniquet in the face of a dangerous setting. So if you're doing this, it's usually in the combat setting or in the backcountry if there's, say, an animal attack or like a rock fall. This is also called a limb tourniquet. So if you're doing something like the high and tight or the limb tourniquet, once the setting is safe, you technically could place a new tourniquet 2 to 3 inches above the wound and then loosen up that limb tourniquet, but then you would leave it in place just in case you need to retighten. When in doubt, or if you only have one tourniquet, however, just leave that first one on and don't mess with it. So typically, if you're not in that dangerous setting, you would just apply the tourniquet about 2 to 3 inches above the wound. The benefit of this is you're just compromising less of the limb if you're closer to where the actual wound is versus at the top of the limb. Either way, make sure that the tourniquet is between the wound and the heart. Make sure there's no foreign objects underneath the tourniquet, so you're checking pockets. Place it over bone, not on a joint. And then you should be checking that the distal pulses should be disappearing. So those are the pulses farther away from the body. So you've got them, say if there's an injury to the leg, you would check the top of the foot, that's the pedal pulse, or on the side, or where your Achilles is, that's your posterior tibial. I believe there's a photo on the next slide. It's helpful to find those pulses before you're applying the tourniquet or as you're applying it. That way you know for a fact it's disappeared because you felt it before and now you know it's gone. You need to make sure that you are stopping the bleeding, not just slowing it down. The tourniquet has to be very tight. Tourniquets are painful and the patient may want to take it off, but you cannot let them do that. Reassess it often, check the site, check for any bleeding, and then check for a lack of pulses. So improvised tourniquets do appear to be less effective, so it is helpful to invest in a legitimate tourniquet. There are various types. In the photo here, that's a cat tourniquet. That can be bought online for about $30, but make sure you are buying one from a legitimate dealer, a legitimate site. There are many knockoffs, so you want to make sure that you're not getting one of those because they really just don't hold up as well. So cat tourniquet is one of the more common ones. Make sure you're getting a new updated version as it can change over time. Another one you might hear of is the pneumatic tourniquet. It kind of looks like a blood pressure cuff. That one's well rated, but it is bulkier and more expensive. Make sure you're watching videos. You can practice at home. And then if you are doing a homemade, any material cloth like bandage, t-shirt that's at least 2-3 inches wide will work. Ideally avoid something that's super stretchy. It's just going to be harder to really make it tight. Some people will say that you have to have a windlass, otherwise you won't be able to adequately stop the blood flow. Standard belts are said to not be effective enough. You might hear of an actual belt tourniquet, but that's a little bit different where it actually has like a ratchet system. It's not just like your standard, normal dress belt. So as you can see in these photos, the one on the left is the cat tourniquet. So we put it on his arm, and then you tighten up the strap just as much as possible, and then you start to turn the windlass until you have lost that distal pulse. Then you'll take the you'll tuck the windlass into that little clip part in the top right corner, take the strap and put it around the windlass and tuck that into the little clip area, and then flap the time over and make sure you write down the time. And then for the improvised, we put a bandana down, took a good nice sturdy stick, tie over the stick, wrap that around just like the windlass, and then secure that stick in place once you've lost your distal pulse. So tourniquet complications, big thing is to make sure that your tourniquet is tight enough and wide enough. If it is not tight enough, then you're going to risk compartment syndrome. So that is where pressure builds up in the extremity below where the tourniquet is placed, and it's from blood pumping into the extremity but not getting out. So this can result in swelling of the tissues and is very painful. You need to get to the ER immediately. Too thin of a material can cut and damage skin and tissue, so tourniquets should be at least 1.5 inches wide. 2 to 3 inches is ideal. Never remove the tourniquet once it's been placed. You do not need to give the limb breaks by loosening the tourniquet over time. Once it's on, it stays on until EMS has taken over. So you can write down the time. You want to write it on the tourniquet ideally. If there's no place to do that, you can write it on their limb. Some people will even write it on the patient's forehead. Just make sure that it is written down and passed along to EMS. So hypothetically, if bleeding were to become controlled and you're in the really, really remote setting, you could remove the tourniquet and place a pressure bandage. But again, this is only for desperate situations where aid is not going to be available for days. And again, this is only if bleeding controlled. But really the rule is just don't remove it. You need to make sure that you're getting to an ER as soon as possible. 2 hours is considered the ideal max amount of time for a tourniquet, and then after 6 hours, we start to have more concern for complete neuromuscular damage. But at the end of the day, life over limb. All right, snake bites. So this is going to be more of a risk with your hike up and maybe that hike back down. Unless you are 100% sure about what the type of snake is that bit you, always treat it like an emergency. Venomous snake bites can cause serious issues, swelling and tissue damage, disruption of blood vessels, issues with blood clotting, paralysis, and muscle breakdown. Non-venomous bites can still cause swelling and irritation. Common symptoms include bite marks, pain at the site, redness, bleeding, low blood pressure, difficulty breathing, muscle weakness, increased saliva, nausea, vomiting, diarrhea, headaches, blurred vision, and dizziness. Treatment is going to include 911 or ER. If you are able to identify the snake, that's great, but do not put yourself in harm's way to do so. You can try to take a photo, but again, don't get too close. It's not worth the risk. Remove any jewelry, watches, restrictive clothing near that area. Keep the bite below the level of the heart. Make sure you're remaining calm and still to try to help prevent the spread of that venom. And then you can cover up the bite with a clean, dry bandage and immobilize that entire limb. And then ultimately the person's going to need an anti-venom. So the don'ts of snake bites. Do not try to suck the venom out. Don't try to suction it or cut into the bite. That's just going to damage the tissue more. Don't apply a tourniquet. Don't capture or kill the snake. You can make note of the color, the size. It might help the emergency providers better treat you, but don't risk getting bitten again just trying to capture it or getting too close. Don't drink alcohol or caffeine. These can speed up absorption of the venom by speeding up our body's circulation. Don't apply ice. Again, that can affect our circulation. And then don't take pain medications like ibuprofen or aspirin because these can increase our risk for bleeding. Acetaminophen or Tylenol has generally been listed as okay, but if you're able to just avoid taking anything, then that's ideal. Moving on to musculoskeletal. So the biggie on this one is going to be our circulation, sensation, and motion, our CSMs. So circulation is going to be looking at the end of the extremity and making sure it's normal color for ethnicity, that it's warm, that you have good capillary refill. Capillary refill is when you pinch the tip of the finger or the toe. The skin should turn pale and then quickly go back to its normal color. So the blood flow is being stopped for a moment after you pinch the skin, and then it's refilling into the capillaries. So this refill should take about 3 seconds or less. If it takes any longer than that, then that's a sign of poor blood flow. This can be from an injury that's affecting the blood flow, or in other situations from dehydration, shock, or hypothermia. Sensation is going to be if the person can feel you touching their hand, foot, etc. Motion is asking the person to wiggle their fingers or toes. Make sure they don't try to move too much, though, if there's any concern about spine or any unstable injury. So all of these CSM tests can help us determine if the injury is cutting off blood flow or if there's any nerve impairment. So for displaced and open fractures, this was kind of a tricky one because there was a lot of varying opinion on what you should do in the wilderness setting. And then it also varies on whether you have experience or if you have no medical experience at all. Generally, what I read was for people who don't have medical experience. Don't try to realign it. You're just going to try to splint that extremity in a position of comfort and then just try to get them out as quick as possible. This is where taking one of those wilderness first responder classes may be really helpful because it can help you learn about traction and about resetting fractures. But otherwise, you want to make sure, again, that you're padding, wrapping that extremity in a position of comfort, and then you want to drape. So I wrote clean, but ideally you're going to do a sterile, moist dressing. However, realistically, who knows what you're actually going to have out in the wilderness. So most resources did say, they said sterile, but they also said the cleanest dressing that you have is going to be the best thing that you can do. Really, we just want to keep that covered because an open fracture has a very high risk for infection, and those people need to get to an ER as soon as possible. Splinting injuries is going to start out with assessment. So asking, can the person use the affected limb, visually inspecting that injured site and feeling the area, and then checking those CSMs. When you're trying to determine to apply the splint, you just really need to use your best judgment, listen to the patient. You probably, you don't need to do full immobilization for a rolled ankle. That's going to be better in 5 minutes. So if there's any severe pain, suspected fracture, obvious deformity, these would all be reasons to apply a splint. Signs of fracture are going to include limited range of motion, tenderness and bruising, pain in the injured area, possible deformity, inability to bear weight, and a grating sensation when moved. So when in doubt, treat it like a fracture. A big question is, can the person still self-evacuate? So, of course, it's going to be ideal to be non-weight bearing, but you're really just going to have to weigh the factors. In a remote setting, if the person can self-evacuate, then that really might be the best, depending on the scenario. So use the tools that you have: jackets, trekking poles, sturdy sticks, branches. I really recommend the SAM splint. It's pretty affordable. I just got one recently. I think it was about $30 maybe, off of Amazon. It's a really lightweight option and it works really well. I like to buy a longer one that you can use for leg injuries, and then if you have an arm injury, you can just fold it in half. Technically, you can cut them, but you have to make sure you have something that you can actually cut into the aluminum with. And again, yeah, these are just available on Amazon. So don't apply a splint if EMS is on their way and near. Really, the splinting topics are geared more towards a remote setting. So continuing on with splinting injuries, again, for that open fracture, you want to cover that open area with the cleanest material that you have. Ideally, it's going to be a sterile, moist dressing, but whatever you've got is what you've got. If you are in the really remote setting and aid is going to be hours and hours away, 8+ hours, do consider also irrigating that wound. clean water is okay. It doesn't need to be sterile. And this is a copious amount of water. So you are just like really cleaning that out to get any dirt, grime, anything out of there, because infection is a very serious concern with any open fracture. And then again, as we mentioned, to reset or not to reset, if you don't have the confidence on this, you haven't had the training, don't reset, just pad and splint that extremity and get them to EMS or ER as soon as possible. For just some rules on splinting, we want to splint in a position of comfort. We want it to be rigid and adjustable, so you may need to make adjustments over time. Swelling can occur post-splint, so yeah, it really does need to be adjustable as you're checking those CSMs and as you're checking for comfort. So add padding to increase comfort. You can that'll also help minimize those pressure points. Immobilize the joints above and below the injury. That splint should stay in place with movement. So make sure it's actually secure. It's not just going to fall off in a couple minutes if they're jostling around. Again, always monitor your CSMs. It's really, really important. Apply the splint so that you can actually see the fingers and toes. Make sure you're actually visually inspecting that distal skin after application of the splint. Feel for their temperature and assess for motion. Pain may obviously limit motion. So even if it's just a small wiggle of the fingers or toes, that's going to count. It's just really has to be the same as what it was before you put the splint on. And then just make sure you're continuing to monitor over time. So you're not just putting it on and never looking at it again. So continuing on to some splinting tips. So for upper extremities, pretty much all of them can be stabilized with a sling and swath, as pictured over here on the right. And this will help improve comfort. For shoulder, you really want to get a sling made. So material is going to go around the neck, cradle the elbow and forearm, and then you can add that swath again to minimize movement. For the upper arm, you want to splint the upper arm against the body. Basically, it'll kind of do same thing for the shoulder. So again, that photo there, the sling with the swath to minimize the movement. Forearm, you want to make kind of like a cast essentially. So you can make a base layer, say like a t-shirt, and then you'll want to put something that's rigid like a stick, again to make that rigidity that we talked about before. And then you can do another wrap over it to kind of add some bulk. And then once again, sling and swath just to immobilize. For fingers, you can do buddy taping and then a hand splint. And I'm just going to back up. There's a little example of the forearm. That's a really good one. One too far. So lower extremity, for knee, you want to immobilize from mid-thigh to mid-calf. Lower leg, you need to do a long leg immobilization. So that's going to be from the bottom of the foot up to the thigh. That's just like that one right there. So it's quite a bit. So with that, do keep in mind that people may need to use the bathroom at some point. So that's where, again, talking about that adjustable might come in handy, or just the way you put it on. You just have to keep stuff like that in the back of your head. For ankle, you want to do a stirrup. So you want a rigid material going from the inside of the lower leg, underfoot, and then to the outside. And then you'll wrap around. And again, I'll just back up real quick. There's a great ankle example. Last is pelvis, so you're going to wrap material around the pelvis, kind of like you're tying a sweatshirt around the waist, but more above just kind of the pelvis gluteal area, and that's going to just help increase stability. All right, neck and back injuries. So you need to determine if the patient is at a high risk of a spine injury. One way you can do this is based off the Canadian C-spine rules. So they define a high risk factor for injury to be age over 65 years, numbness in the extremities, or a dangerous mechanism of injury. So those can include a fall from greater than 3 feet or 5 stairs, any axial load to the head, so think of like a football player ramming into something with his head down, a high-speed motor vehicle accident, or a bike collision or any sort of collision. I think paragliding would also fall under this. So again, those are the Canadian C-spine rules. So if they fit that criteria, they would be considered high risk. We want spinal cord protection via spinal motion restriction. So the goal really is to minimize the risk of missing and or exacerbating a potentially unstable spine injury. Mobilization is no longer the goal when it comes to spine injury management. Research is finding that there may be increased morbidity and mortality related to that spinal or total spine immobilization. So the preferred position of an injured spine is going to be neutral alignment, and the only reason you wouldn't do that is if you find that with moving the patient there is resistance, increased pain, or new and worsening neurological deficit. So should you do a spine assessment? This really isn't an appropriate presentation to teach you how to clear a spine. If you're near medical care, just perform those spinal cord protection methods, keeping them still, and then wait for EMS. If you're in a remote accident, that's when you start to consider that, but really you should take a wilderness first responder class, and they can actually teach you hands-on how to clear a spine. Incorrectly doing this can have serious risks, so you really want to get further training on this. Don't worry about carrying a C-collar with you or a backboard everywhere. Recent guidelines have found that not having these tools hasn't been associated with harm, but actually sometimes having these tools can cause harm. So just clearly instructing an alert and oriented patient to reduce their movement of their neck is sufficient. Backboards are moving for moving patients only. It's not an immobilization tool. So if you have to carry someone out of the wilderness, package that patient in a way that reduces that passive cervical motion. If you need to move the person out of harm's way again, attempt to maintain that spinal motion restriction. Research has actually shown that self-extrication can reduce spinal movement better than assisted extrication. So I thought that was pretty interesting. The Wilderness Medical Society has reported little evidence that supports the use of C-collars. These can actually cause more issues, and if you are going to use one, they recommend soft collars over rigid collars. And here in this photo, this is an example of the trap squeeze method for stabilizing a spine. He's just grabbing the top of my shoulders, and he is truly keeping my head in place, but also sometimes just having something there next to the person's head helps remind them not to move. So if you're by yourself, you could take even 2 harnesses and just put them next to the person's head, just as a little reminder of like, hey, don't move. And that can actually be really helpful. So for head injuries, we'll start out with concussions. These can occur with or without a loss of consciousness, and they don't always require a direct impact to the head. Symptoms are going to include headache, neck pain, emotional disturbance, memory problems, confusion, nausea, blurred vision, poor balance, slow response, drowsiness, and light and noise sensitivity. Some people might deny that they have a head issue, but people around them might notice the signs of irritability, sensitivities, confusion, etc. So just keep an eye out for anyone who could have a concussion. For severe brain injury, some of the indicators for this would be prolonged loss of consciousness, under 13 and over 65, if they're on any bleeding medications or have bleeding disorders, if there's any substance abuse, any seizures, signs of skull fracture, persistent vomiting, or if it was a high injury mechanism, such as paragliding, and then if there's any worsening symptoms with time. Again, those are all indicators of a severe brain injury. So any of these symptoms would warrant a 911 evacuation. One of the big differences between mild and severe brain injuries is that worsening and progressive deficit. So prevention, wear that helmet. Obviously a helmet might not help a ton in something like a midair accident, but it really could make a difference with a launching or landing accident. So continued, for assessment, you want to ask those A and O questions. Again, that's going to be, who are you? Where are we? What is the year? What are we doing? What was the situation? Have them perform small tasks like tying a knot or counting odd numbers backwards. And if those activities are particularly challenging or slow, then a concussion would be likely. Concussed people do need to evacuate. Research has shown that continued exertion will worsen symptoms, and it can actually prolong recovery. So symptoms will determine the type of evac needed. With a mechanism of head injury, watch out for, of course, any spine injury. And then for severe head injury, or if they are unconscious, you want to watch for any seizures or change in breathing. If they do have a seizure, make sure you're not placing anything in their mouth and turn them on their side. They could vomit, and then make sure you're calling 911. So really watch breathing, and then start CPR if needed. So acute mountain sickness is also called high altitude sickness. This typically occurs above 8,000 feet, and it can take a few hours for symptoms to actually appear. If you're traveling to a high place for flight, give yourself about 2 to 3 days to acclimatize, and that would start at about 8,000 feet. So increase your elevation by about 1,600 feet per day, and then add an extra day for every 3,000 feet. Since AMS takes a few hours before symptoms occur, it's probably going to be less concerning for most pilots, but it is something to keep in mind if you're traveling to high altitude for a flight or if you're flying for a really long time. If you know you'll be at high altitude for a prolonged time, you can talk to your healthcare provider about preventative medications such as Diamox. That is more of a preventative versus treating it once you've gotten the symptoms. But symptoms of AMS are going to include headache, nausea, fatigue, loss of appetite. Headache is that cardinal sign, though, and it can occur within 2 hours of arriving to that high elevation. Complications of AMS. First, we'll talk about HACE, so that's high altitude cerebral edema. So this is when leaky capillaries in the brain result in fluid accumulation and swelling. Without immediate descent, death can occur. So HACE is rare. Symptoms are going to include profound lethargy, confusion, ataxia, and difficulty with speech. Ataxia is a loss of coordination with the muscles, so you can see trouble walking, trouble balancing, or slurred speech. High altitude pulmonary edema is HAPE. HAPE can be more rapidly fatal than HACE, and its symptoms are breathlessness, weakness, and a dry cough. So both are very serious and life-threatening. You need to descend immediately. Both rarely occur below 10,000 feet, but it is possible. At 13,000 feet, the prevalence of HAPE is 1.7% and HACE 0.98%. Incidences do increase with a rapid ascent, though. So again, we want that slow and methodical increase with elevation. For treatment, again, it's going to be descent. That truly is the best treatment. Oxygen can be used, steroids and antiemetics, which are anti-nausea medications, but you will need a prescription from your healthcare provider. Over-the-counter medications like Tylenol or NSAIDs like ibuprofen have been found to be helpful with symptoms of AMS, but before you take any medication, prescription or over-the-counter, make sure that you're checking with your healthcare provider to ensure there's no contraindication for you taking that. And just something to think about. So at 18,000 feet, you're getting about half the oxygen that you normally would get at sea level. The FAA requires flight crews to use supplemental oxygen once a flight duration exceeds 30 minutes while at 12,500 feet to 1,400 feet. So at 1,400 feet, supplemental oxygen must be used immediately and for the rest of the flight. So oxygen deficit can sometimes create a sense of euphoria, and people are unaware that they're experiencing those symptoms. The FAA had a study reported where subjects didn't feel the symptoms of oxygen deficit, but were unable to write their name legibly, and they were unable to sort a deck of cards. So, food for thought. If pilots are doing that, then maybe paragliders should too. And I know a lot of people do that, but it's just something to think about. So drowning is going to be more of a problem with water landings. First thing you want to do is call 911. Unlike the normal ABCs with drowning, you actually will begin with your rescue breathing, and then you'll do your chest compressions. So if the person arouses, you want to treat for hypothermia, know that they may vomit. Make sure you're watching closely for any respiratory changes, and then again, just watching their temperature, and then you need to get them out of there. So I recommend flying with a knife or inflatable personal flotation device. There we go. Those are about $50 to $100 on Amazon. If you know you're going to be over water, it's probably worth just grabbing one. And then the hook knife you can just strap to your harness, and that will help you cut away lines. Don't become a second victim. Use extreme caution when you're rescuing in water. And this is just your second reminder to take that CPR class. It's really important. Hypothermia can come in different severities, so mild, moderate, and severe, and it all comes down to body temperature. So, in a remote setting, obviously this is going to be more on presentation, unless you happen to fly with a thermometer. Normal is about 37 degrees Celsius or 98.6 degrees Fahrenheit. Mild is going to be a core temp of 93.2 to 96.8 degrees Fahrenheit. Moderate is a core temp of 86 to 91.4 degrees Fahrenheit. And then severe is going to be a core temperature of less than 30 degrees Celsius or 86 degrees Fahrenheit. And I throw in the Celsius just because us medical people go by that. So again, normal, 37 degrees Celsius, 98.6 Fahrenheit. Severe, 30 degrees Celsius, 86 Fahrenheit. Sometimes these signs are not obvious. You might only just see agitation or a flat affect, which is where someone's just kind of low, no emotion, and those might be the only symptoms that you see at first. So early signs can be variable and hard to evaluate. Symptoms of mild are going to include shivering, confusion, impaired judgment, slurred speech, amnesia or memory issues, nausea, and increased urination. Moderate, you're going to see lethargy, hallucinations, ataxia, which is again that loss of coordination and balance, maybe some slurred speech, worsening mental status, and then you're going to lose the shiver. So you could also start to see some of that paradoxical undressing, which is when people take clothes off because they think that they're warm. You might see some psychoses and neuroses. Severe is the progression of the moderate symptoms. You can start to see hypotension, which is low blood pressure, low cardiac output, coma, and death. So shivering is an important sign. Mild and moderate are kind of hard to differentiate. With mild, you're going to have some impaired movement. With moderate, you have that loss of alertness and the shivering slows or stops. And then moderate, you'll start to see hypoventilation, which is lower rate of breathing, bradycardia, which is a slower heart rate, and then hypotension, again, that low blood pressure. Cold stress, on the other hand, is when someone is cold, but they have that normal mental status and coordination, they're alert, they're shivering, so they're not actually hypothermic. So treatment for hypothermia. First goal is going to be prevent further cooling. You can do passive rewarming. That's going to be removing the person from wind and moisture. You want to insulate them from cold surfaces, remove any wet clothing, add dry insulating layers, and wrap them in a space blanket, and make sure to avoid alcohol. Keep the patient horizontal, keep them wrapped in dry material, and insulate the patient from the ground. So passive rewarming should be enough for mild cases. Ingestion of warm fluids and adding in calories can be beneficial, but we want to avoid caffeine and alcohol again. And the ingestion of fluids really, so it's helpful, and the main goal actually is for fluid balance due to the dehydration from the body's response of urination during hypothermia. So hypothermia places a high metabolic demand on the body, so the patient is going to need those extra calories. And then we say avoid caffeine and alcohol because we want to avoid further urination. For active rewarming, you can use external heat sources like hot water bottles, chemical heat packs, skin to skin, fire heat, forced air, warming blankets, but make sure anything that you're adding to the person, you want to watch for any burns or skin irritation. And when you do add things like hot bottles, you can put those by the groin, near their chest and abdomen. So moderate and severe, you're going to definitely need active rewarming. Immersion in warm water is not recommended due to the risk of shock. So warm water rewarming can lead to peripheral dilation, so opening up of those blood vessels in the peripheral extremities, and then that can lead to hypovolemic shock. The hypovolemic shock can then lead to ventricular fibrillation, and that is a scary heart rhythm that can lead to death. So there were some studies that varied on this, but all the current guidelines recommend that you do not do this. So more on hypothermia management. It's important to carefully handle the patient if they're in that moderate or severe hypothermic state. You want to move them gently to avoid triggering any cardiac event. Keep the patient at a horizontal position, and then just keep in mind that a patient in severe hypothermia is at high risk for that VFib heart rhythm. You want to make sure that EMS and ER are getting involved for any moderate or severe patients. And then watch out for something called the afterdrop phenomenon. So that is thought to be from cold blood in the extremities entering the warmed up core. So this can cause cardiac events, and it can actually occur for up to 30 to 40 minutes after exiting the cold setting. Pretty interesting. Make sure you begin CPR right away if no pulse is present, but keep in mind that vasoconstriction, or tightening up of the blood vessels basically, when someone is cold can make it really hard to find a pulse. So opposite direction, we'll go to heat illness. So various different types. Heat cramps is just muscle cramps during exercise, and these are going to be most associated with dehydration or electrolyte imbalance. Heat syncope is a transient loss of consciousness due to heat exposure with a quick return to baseline. So this can be from prolonged standing, older age, dehydration, exertion, and syncope basically means passing out. Heat exhaustion results from exposure to higher temps or strenuous exertion, and this can be mild to moderate, but it can progress to heat stroke if it's untreated. So core temp is normal or slightly elevated. For heat stroke, you're actually going to see a core temperature above 40 degrees Celsius or 104 degrees Fahrenheit with central nervous system involvement, and that's kind of the key there. So this can be from passive exposure to heat or from hyperthermia during strenuous exercise. Opposite to all this, hyperthermia is just a natural response to exertion or exposure to elevated temperatures. So it's just a deviation above the body's normal temperature, and it doesn't necessarily indicate heat illness. So hyperthermia is when the body temp is around 40 degrees Celsius or 104 Fahrenheit. It can be asymptomatic in athletes, and the relevance really just goes to show that temperature alone doesn't necessarily indicate heat illness if the person's asymptomatic. It, again, is that involvement of, for the heat stroke, involvement of the central nervous system. So prevention is going to be our biggie here, staying hydrated. However, hyperhydration before activities hasn't actually been found to be effective. Basically, you just want to be, baseline hydrated and then drink when you're thirsty. Acclimatize to heat before big outings. So you can do that 1 to 2 hours per day of heat-exposed activity for about 8 days before you have your outing planned. Symptoms of heat exhaustion are going to include weakness, fatigue, thirst, headache, nausea, dizziness, and muscle aches. Heat stroke is going to be that central nervous system involvement. You'll have abnormalities like altered mental status, seizures, and coma. Obtain a temperature if possible, but nobody expects you to be flying with a thermometer. So treatment for heat cramps is going to be fluid replacement. For heat syncope or passing out, you're going to do passive cooling and fluid replacement. For heat exhaustion, you want to do evaporative, convective, and conductive cooling, and then fluid replacement, and we'll talk about all these in the next slide. And then heat stroke, you want to monitor your ABCs, do cold water immersion, and then conductive cooling. So passive cooling is going to be moving the person out of the heat into the shade. Look for ground that's cold or any insulating barrier to the ground that might be hot. Remove or loosen any tight clothing. Make sure that you're helping the person become hydrated. So start with oral hydration, but if the person can't keep any fluids down, then you definitely have to pursue medical care. Cold water immersion is the optimal field treatment for rapid temperature reduction. So the colder the water, the faster the rate of cooling. You want to remove any insulating clothing and submerge the person's trunk and extremities in the cold water. If you are using a stream or river, be really careful of currents and make sure that you're not submerging the person's head. So never leave someone alone in the water, of course. There was a supposed concern that cold water immersion could actually cause peripheral vasoconstriction and then shivering, which could slow cooling. However, that has been deemed a misconception. You can also have a person lay on a tarp, apply ice and water to the body, and then wrap them up like a taco in that tarp. Evaporative cooling and convective cooling is when you loosen and remove clothing, you douse the person in cold water, fan them for airflow. It's not very effective. Conductive cooling is using ice packs and wet cloths applied directly to the body. Again, not super effective. Ice packs and cold cloths are more effective when wet and covering the entire body. Antipyretics, which are fever-reducing medications like Tylenol, ibuprofen, have not been found to be effective, so it's not recommended that you give them. All right, now psychosocial care. So psychological first aid, this is really, really important, and I feel like sometimes it doesn't get the attention that it deserves. There's 5 components that are laid out for psych first aid. First is to create a sense of safety. So reducing the chaos, remove the patient from any perceived threats, explain to the person that they are safe related to weather, location, whatever it is to show that the threat is gone. Create a sense of calm. So calming yourself, speaking and acting calmly. You can take deep breaths, give yourself a second to compose if that's what you need. Create self and collective efficacy, so involving the patient in decisions, having them participate in self-care as much as possible, allowing them to help problem solve, and have them help with the rescue. They might have some really good ideas. So remind the person of their strengths and remind them that they are a part of the team. Create connection, so build relationships, use their names, create a partnership with the person, especially if it's someone you don't know. You know, it's awkward to have somebody that you've never met before helping you out, so really trying to create a relationship as much as you can. Help the person connect with family, friends, or even pets. And then finally, create hope. So reflect on accurate and specific positive facts, but don't lie or make things up. Create realistic goals, and make sure you're also personally maintaining hope as well. So you want to employ these throughout the entire rescue process. It's okay to ask others to step aside if they inhibit the ability to maintain that calm and safe environment. And keep yourself accountable too. It's okay to step aside if you're unable to remain calm, and just take a moment to compose yourself. So acute stress disorder and PTSD can occur for responders and for the people who are injured. Acute stress disorder is the initial symptoms that occur immediately after a traumatic event and last for up to 1 month. These can involve physical symptoms, psychological symptoms like anxiety, low mood, irritability, insomnia, isolation, mood swings, avoidance, and emotional numbness. Their physical symptoms with acute stress disorder can include heart racing, chest pain, headaches, abdominal discomfort, and nausea. With post-traumatic stress disorder, or PTSD, symptoms will be occurring for longer than 1 month after that traumatic event. So this can include flashbacks, nightmares, severe anxiety, avoidance, and uncontrollable thoughts about the event. So follow up with your primary care provider or your mental health professional. Getting treatment as soon as possible can help prevent these symptoms from getting worse. Check in with your friends after traumatic events. Look for those symptoms that could suggest that they are struggling with a stress disorder. Obviously, don't force discussion on this person or be too pushy, but do offer help and offer more than once, because sometimes the person might not be ready to talk at first, but if you bring it up again a couple days later, a week later, they might be ready to open up. So our last section is going to be logistics. So for first aid kit supplies, I recommend starting with a lightweight kit, such as one for backpackers. You can get these on outdoor retailer websites. And then I like to just kind of add my own supplies to these pre-made ones. So fine tip syringe is great for irrigation, extra over-the-counter meds and antibiotic ointments. Things that I like to add include Benadryl, ibuprofen, Tylenol, GI meds. You can throw a tourniquet. Some people even like to carry these in their purse daily. First aid pocket guides are great. These can be found, again, online from usually outdoor retailers' websites can have these, and then wilderness education resources and websites can have these too. Throw in an extra pair of gloves, and then rope or tape is really helpful. Make sure you're flying with water and an extra layer that can be used for splinting wounds, and then a communication device and extra batteries. So you don't have to carry a huge first aid kit with you everywhere, but it is smart to have at least a couple supplies in your pack. Keep in mind that most accidents result in musculoskeletal injuries, and fatalities are a result of major trauma. So the most important resource to have is going to be that means of communication, so cell phone, satellite phone, spot beacon. So the Good Samaritan laws can vary by state, so make sure you're checking these before you fly if you're going from state to state. So I looked up Utah because that's where I live. So I'm just going to read the law here. So a person who renders emergency care at or near the scene of or during an emergency gratuitously and in good faith is not liable for any civil damages or penalties as a result of any act or omission by the person rendering the emergency care, unless the person is grossly negligent or caused the emergency. So negligence is a mistake or inattention that causes injury, and gross negligence is the conscious and voluntary disregard to use reasonable care. So only do what you've been trained to do. If you are a healthcare provider, you cannot receive payment for your aid and still be considered a Good Samaritan. Implied consent is present for those who are unconscious or unresponsive. So bottom line, if you're helping in an emergency, generally you cannot be sued if the victim is injured by your good intentions. And the exception to this is if the emergency is your fault or if you were grossly negligent. Rescue in Utah. This was pulled all from the utah.gov website. Rescues can cost between $2,000 to tens of thousands of dollars. Some counties don't charge victims at all, and others might. So again, it really depends on where you're flying and kind of what the situation is. Utah offers a Utah Search and Rescue Assistance Card. This allows recreationists to help contribute to search and rescue efforts, or SAR. So it reduces the chance of being backbilled for a rescue. So you can still be charged if the rescue was based on reckless acts or an intentional cause. They define a reckless activity as a person who acts recklessly when he or she engages in highly unreasonable conduct involving extreme departure from ordinary care in a situation where a high degree of danger is apparent. And then for the intentional is a person who intentionally takes actions to incur a SAR response, is one who has done it purposely or deliberately, not accidentally or involuntarily. So as long as you're not doing those two things, then this card would help protect some of your costs. So you can do a 1-year card. It's $25 for an individual, $35 for a family, or there's a 5-year card, which is $100 for an individual and $140 for a family. We'll say, check up on these. It's August of 22, so if you're looking at this video later on, I don't know if things have changed, but at least at this point in time, that was the cost. So having the card makes your non-medical charges, such as helicopter and other equipment in general, eligible for reimbursement. So patients are still responsible for their medical and health-related charges. So make sure you're checking with your specific insurance on what is covered for that. But again, the helicopter equipment stuff can still be tens of thousands of dollars. So this is a really great opportunity for people to get. So consider that card to help protect yourself from the possibility of reimbursement charges. And the proceeds go to helping SAR. So it's really a great thing. Even if you don't use it, you're helping out with our local search and rescue. Each state varies, so some will only charge the person if they're entering closed areas, if they're going out of bounds at resorts, or if the cost surpasses a certain number. So most states do have a card kind of like the Utah Search Card. All right, so helicopter rescue. Just want to make note, I've not been a part of a helicopter rescue myself, but I did look up just some general guidelines on helicopter rescue procedures. So mark your location with bright colors and equipment. Your wing could come in handy for this, but make sure you do have it anchored down securely. You want to avoid and remove any loose objects in the LZ. LZs are usually 100 feet by 100 feet, and they ideally will be a firm, flat surface, away from any power lines, poles, buildings, etc. Approach the helicopter only if and after the pilot has motioned you to do so. Follow all their commands around the helicopter. Don't approach it from uphill. Don't walk behind it. And again, only approach from the sides after being told by the crew. And you can review helicopter signals online. For communication with EMS, this is going to vary if it's being done in person or if it's remote. Some details are going to be more important to share if you're in that remote setting, and you'll need to discuss evac plans. So those would be kind of the big differences there. If you have time, it's helpful to write out a SOAP note to make the report a little bit easier. A SOAP note is the standard form of communication in healthcare. It stands for Subjective, Objective, Assessment, and Plan. So you really want to make sure that you're being succinct and thorough. Only report the essentials. You want to know the purpose of your call. You want to have all your details laid out. Proper communication on a radio is slow, clear, and monotone. Make sure you're reiterating your most important facts, ask for clarification, and then you can utilize that read back, repeat back by you and the other person to ensure that you're understanding. Make sure you're familiar with your communication devices before you're going out, especially in remote settings, and then gather as much information on your location beforehand if you are out in the remote setting, GPS coordinates if possible. And do keep in mind, having given report to EMS, they are moving quick. So, if you're dilly-dallying and saying things they don't care about, they are going to walk away. So again, be succinct, be thorough. So, anatomy of a SOAP report. Starting out with subjective, so you're going to give a quick summary of what happened and the brief history of the issue. Chief complaint is going to be your main injury or issue. You're going to report what the patient is complaining of and any symptoms they're experiencing. And keep in mind, I said, the thing that they're reporting. they might say their ankle's hurting them the most, but if they're having difficulty breathing, the chief complaint is going to be the breathing. So it's really kind of the biggest issue at hand. You can add in any pertinent patient information, so age, gender, allergies, past medical history. Moving on to objective, so this will be your vital signs, your A&O, heart rate, respiratory rate, skin, pupils. You can cover all your exam findings, how you found the patient. It is useful to include the most important absent findings as well as normal findings. So, for example, you can say there were no obvious musculoskeletal injuries found, or you can say CSMs are normal in all extremities. For assessment, you're going to reiterate your main findings, so list out those most important problems. For example, patient has a severe injury to her left ankle and is unable to self-evacuate. Plan is reporting what you have already done and what you're planning on doing. Listen to what they recommend you do while you wait. If you're in a remote setting, what are you requesting? Do you need immediate evac? Be ready to know what you want to ask them for. All right, last slide. Recommended resources. So I highly recommend taking a wilderness first aid class or wilderness first responder class. These are really great. You can learn so much. Get CPR certified. This is actually included in a lot of those wilderness courses. First aid and CPR courses will help in every aspect of your life, so really worth it. Another resource is just looking within your own community. I was actually scrolling through Facebook the other day and saw that a fire department was doing free CPR courses and free Stop the Bleed courses. So really awesome. If you're in Salt Lake, that was at the West Valley Fire Department. So highly recommend checking that out. Make sure you carry a first aid kit, have a bigger one in your car, talk with your friends about what to do in an accident. So discussing pertinent health information with one another, talk about your allergies, medications, any important health history like those seizures, diabetes, heart or lung diseases. You want to know that ahead of time. And again, obviously keep that amongst yourselves. Give that person privacy and respect if they have shared that information with you. The Utah Search and Rescue Card is an awesome resource. There is the link right there to more information on that. There are so many academic resources online. I personally really like the Wilderness Medical Society practice guidelines, and then I like to look at the National Outdoor Leadership School, the Knowles blog. Those are just two of so many that you can look at, and they've got a lot of info that's really helpful. If you are learning online, just make sure that the information that you're reading is up to date. So if ideally within the last couple of years, if you're reading something like guidelines, those can be updated. Some of them can be updated yearly. So just make sure that you're looking at the most recent year. And here's some of my references. All right, and that concludes our presentation. I hope you were able to learn something valuable from this and that it could help you lay that just foundation of wilderness medical knowledge. Paragliding is an amazing sport that unfortunately does come with risks. We can help mitigate those risks by just increasing our knowledge and skills as responders to various emergencies and also just as pilots. Please see my contact information and reach out with any questions or comments. My email is listed right there. I'd like to give a specific thank you to those who helped me with this presentation. In particular, with the content review, I just want to thank paramedic Jason Ball, Dr. Ben Moody, and Dr. Cecilia M. And lastly, I just want to thank everybody who's listening right now. I wish you all safe and happy flying, and I look forward to seeing you in the air.